coming to you from Little Rock, Arkansas, and today your organizers asked me to present in this mini series, which is really about the community engagement and citizen science and implementation science, which is in service of promoting health equity, a lot of where my work has been and is right now. And I'm excited to share that with you today. I've got some kind of mindsets to share with you with some tools from other folks. And I've got some tools my team has created that are publicly available for use called Consumer Voice, and some examples of how they could be applied to ending the HIV epidemic, or how they are or will be soon. And then we can definitely jump into question and answer, and obviously have our consultation time then afterward. I'm putting in the chat, if you want to get in touch with me afterward. I'm still using X. It's like I just don't have the energy to move somewhere else right now with that, but lots of good conversations I've had. And then there's my email that you can contact me at. Okay, a couple of important disclosures. I am not here in my official capacity of any of my employers, but I am an employee or a consultant for the Veterans Health Administration and the University of Arkansas, but also for ViiV Healthcare, which is a pharmaceutical company doing a lot in the HIV realm. And nothing from what I'll say today, represents the views of the federal government or any of my employers. So that's an important thing for you to know. Okay, we have all come from a lot of different places. You might be in many different time zones, and I just want us, to be able to be here now. So let's take a quick moment to get present. As I shared in the chat, I am a psychologist, so you're riding along on psychology waves with me. We're going to do a brief mindfulness exercise just to make sure that, we're able to be here now. You're able to come here and engage with this for whatever reason is important to you. Your time is precious, your energy is precious, and I want to make sure you get the most out of it. So go ahead and minimize emails. Put the phone away for the next 50 minutes. And if you are driving, you can still do this without closing your eyes. Go ahead and make sure you're seated in a place where you're comfortable but won't fall asleep. I'm going to close my eyes, but you can also just shut them to where there's a little bit of eyesight peeking through, like close them 8/10 of the way, or even just pick a neutral spot and stare at it. And just first noticing where your body is meeting the seat that you're in. Noticing which parts of your body are not making contact with the seat or a computer. And as you take your next breath in, noticing that breath, even saying to yourself something like breathing in. And as you exhale, noticing and acknowledging that breathing out. Your thoughts may wander, and just coming back to breathing in and breathing out without trying to change your breath. One more round of breath. And then kind of flittering your eyes open, coming back to the screen or the audio, wiggling or adjusting as you need to. Thank you for doing that with me and just getting us present here. We are definitely going to talk about community engagement in implementation. And one important reason why I am doing that is that I theorize that that might be an essential element, although not sufficient, for equitable implementation. And when I start to talk about this topic, like health equity and implementation science, it gets really overwhelming for people, and it can be overwhelming for me sometimes. Um, and that makes sense. Getting anything implemented anywhere is complex and difficult and involves multiple levels and multiple players and people. Then making sure that the innovations that are effective reach people um, who really need it the most, who experience a lot of disinvestment in their communities and marginalization socially, is also complex. So you've got those two complex things coming together, and it's not simple. And so there's one mindset that I want to offer to you today that I really have come to accept myself, which is really for equitable and just implementation of innovations, we really must embrace complexity and realize that these are career long and lifelong endeavors. And as I go through some of the material today, or any talk you have in the series, I'd encourage you to think about what's the most elegant next step for you, not for anybody else, not for what I'm throwing out there, but there's probably at least one thing that you came to hear about today, something you could take away and incorporate into wherever your work is now. And that's a question from Adrienne Ray Brown, the author of Emergent Strategy. What is the most elegant next step for you? Okay, we've got our slides up and going now. All right, Carrie, we're going to do a next situation. Keep going. There we go. Okay, one more. Okay, just to make sure we're all tracking and on the same page. Sometimes the people who need quality care the most are actually the least likely to receive it. This has been documented even in the 1970s as the inverse care law, but we know it best today as healthcare disparities. And so these are, you can go to the next slide, Carrie. These are situations in which there are disparities and which is an unjust or unfair difference in the receipt or quality or outcomes of care that's not due to patient choice. So I want you to engage in a multiple choice question answer in the chat. You're in your field where you're working, you are aware of healthcare disparities in either A, structural access to the innovation. So the innovation is the practice, the program, the medicine, the policy that you want people to receive and realize health benefits from. This could be HIV testing. This could be treatment as prevention. This could be PrEP. It could be some other sexual risk reduction program. So structural access to those things, like it's out there, but people have very few chances to even get in line for it. So is it that you know about disparities in structural access? And then B would be receipt of the innovation. So you're aware of healthcare disparities in that it's being offered and people can get in line for it, but some subgroups are less likely to be offered it than others. Or C, the quality of the innovation. So some people are receiving it, but with worse fidelity or patient-centeredness than others. Or are you aware of disparities in D, in your field, outcomes of the innovation? So people are actually receiving, let's say, um, PrEP equitably, but they're not benefiting as much as others. So are you all, Portia says all in all caps. Okay, so some people are chiming in and saying, there's a lot of disparities in structural access for me, receipt of the innovation, and then the quality of it. Okay. If you're sitting here and you're not sure about the answer to this question, that's your cue, that's your one elegant next step. to, or it could be, to go look into the literature, look at some reports, that are put out regionally or by ministries of health or departments of health in your area, and and get an answer to this question. Okay, thank you all. It kind of orients me to where you're at. Okay, so I am going to share a brief overview of implementation practice, which is part of every implementation trial, even if it's called that or not, because everything we're going to talk about today is really about engaging end users, engaging recipients of the innovation in implementation practice. Okay, so let's dive in. Next slide. The paradigms of implementation science and healthcare disparities follow similar steps to detect, understand a problem, and then reduce those gaps. So, for healthcare disparities, it's detecting gaps in, structural access, you know, receipt or quality of the innovation. And again, that's the differences are unjust, they're unfair, they're not due to like end user choice, and they're usually worse for groups who experience a lot of marginalization, such as based on race, like Black Americans or people that are refugees in different countries and experiencing a lot of social chaos and maybe oppression in their home country. It could be sexual and gender minority people. So the paradigms of these two scientific fields follow similar paths, that you want to detect a problem is there, and then you want to understand why it exists, and then you want to do something to reduce those gaps. And sometimes your science for your innovation, let's say it's antiretroviral adherence for HIV, there might be a lot of, you might be ready to reduce the gap. You know where there are disparities in the receipt of that, um, in receipt of innovations for that. Scientists in your field understand why that exists, and you're really at the point where the science is demanding to do something about that. But maybe with reducing disparities, you're not exactly sure yet. And so you might have studies with an aim that's really around reducing the gap with implementation strategies on, in one aim, and then maybe understanding some of those disparities in implementation still on the other. It just depends where the evidence is in your field or your area. Okay, click, and I'll just make clear about how implementation practice comes in. Implementation practice, or the active use of strategies to increase uptake or adoption of an innovation, happens when we're ready to reduce gaps in science to practice or for healthcare disparities. And implementation practice is really determined by what we learn in the understanding phase. So just like you wouldn't go to your own healthcare and just let them operate on you for a problem without a good diagnostic assessment first, neither in implementation practice should we be going into settings and offering them strategies when we haven't first tried to comprehensively assess or diagnose the why that's happening. Same with disparities issues. And that's a good reason to use things like the health equity implementation framework for those really thorough assessments. So we're going to really be talking about the reducing the gap in research to practice and disparities today. Okay, we've set the scene. Let's go next. There are multiple clusters of implementation strategies, just to give a brief overview on this slide. And these are emerging and changing all the time. But these are some of the core groupings of many strategies. You can see engaging consumers at the top, and that's what we'll really focus on today. Changing infrastructure, such as physical structure, perhaps. Adapting and tailoring either the intervention or the strategies to context, which could happen through quality improvement cycles, for example. Developing stakeholder interrelationships, so helping different people in an organization come together, supporting the clinicians there if it's a healthcare setting, or if it's an educational setting, it might be educators or administrators, for example. So there's lots of different clusters of strategies, engaging consumers being one of them. Okay, next. And giving everyone the same implementation strategy is not equitable, although it can be easier. Next slide, let's take a look at this visual by the Robert Wood Johnson Foundation. So you see on the top, there is equality pictured here. So there are four people and 4 bicycles, and all the bicycles are the same size. And so there's a person using a wheelchair that can't even get on the bicycle. There's a much larger person that is on the bicycle but looks very uncomfortable. And there's a very short person who can't even reach the pedals. They're using it, but not completely. And equity is what we see at the bottom, where the bicycles have been adapted to each person's needs. So the person using a wheelchair has a hand trike, and they can actually use their hands to get where they're going rather than being unable to go anywhere on the bicycle. The much larger person has a much larger bicycle. So this is, what can happen in implementing innovations anywhere, is that it's a lot easier to give everyone the same thing. And when that happens, we absolutely must expect that there are people that will not be positively affected by that. And in fact, might even be harmed by that. And those individuals are likely to experience exclusion or disinvestment or marginalization in other areas as well. And that's the inequitable implementation problem. Okay, next slide. So how do we make sure that implementation is suited, the implementation strategies are suited for different populations? One major way that we are at in our field is through tailoring, and it appears really important for uptake. So tailoring is when someone or you have done that good diagnosis, assess the relevant determinants, and then design or change the strategies to address those determinants and the needs of all the people involved in that context. And there's increasing science that shows that tailoring implementation strategies might be much more effective than one-size-fits-all approaches. So that's, it might lend itself more to equity, although we don't know that for sure. That's still a scientific question. Next slide. So this is one important mindset that I'm operating from, just to make it explicit to you all, which is engaging end users or the recipients affected by the health problem is the gold standard in health disparities research, and probably should be in implementation science too. And there are more people talking about this than me, but that's an explicit assumption that I have, that I want to just make clear going forward, and I'm operating under. Next slide. We're going to talk all about this now. So one reason why that seems like a good idea to me is that there is preliminary evidence to suggest that that's important, that engaging end users in implementation can lead to a better intervention fit for patients, better systems redesign in settings that's more patient-centered. And this is in healthcare settings, greater use of effective healthcare interventions. So there's better uptake when end users are involved, and improved patient health behaviors and outcomes. It's not, I wouldn't say engaging end users in implementation is something we're really robustly doing as a field, but some people have been doing it and are doing it. And in those cases, it looks like it helps many different aspects, many different things. Okay, next slide. And because groups of people have been caring for themselves for generations, with or without your help or my help or our help, they can and must care for the research in their communities. So if you'll click Carrie, there's an animation here. This is especially salient for Indigenous and Native American populations. So a quote here, that information, data, and research about our peoples collected about us, with us, or by us belong to us and must be cared for by us. So engaging end users, I believe is also more of an ethical imperative and the right thing to do. And that's based on much complexity. So when it comes to implementation strategies, again, to revisit that with some sense of why it might be important to engage consumers, let's revisit those 9 clusters again. So you've got the engaged consumers category. And if you'll click next, Carrie, there's a few animations on this slide. The 5 types of engaging consumers that are currently delineated in an implementation science field involve these 5 things: using mass media to reach people, involving patients in uptake or adherence of an innovation, involving patients and consumers and family, preparing patients and consumers to be active participants, and also engaging consumers to increase demand for the innovation. Now, there are fields that do this really, really well, people in public health especially, and health promotion especially have a lot of training, skills, and experience in engaging consumers. And they might or might not have more of the implementation science piece. And bringing it all together could be more powerful than each field alone. So these are the current 5 ways that are named or delineated in the field at present for how to engage consumers. If you'll click Carrie. And actually preparing patients and consumers to be active participants ahead of time has some of the strongest evidence that it helps with all outcomes for implementation compared to many other strategies. Now that evidence, again, is newer, but a very recent review that was prompted by Pecori, cited at the bottom, just got released, and they did intense literature reviews of all the studies that tested implementation strategies and found that actually preparing patients and consumers to be active participants in their own care is really effective for uptake, outcomes, etc. And if you'll click. But in general, the engaging consumers cluster does not have enough specificity to be totally actionable. When I first looked at these 5 ways in which consumers could be engaged, and this was almost 10 years ago now, I thought, okay, this is great that this is out here, and also I don't know how to do that. And I don't know almost what any of those really mean. And, that's just because that's where one of the cutting edges that was, less defined and less clear and less robustly known in our field. So that's where a lot of my science is going and is right now. I'm going to pause for a question in the chat. Okay. Porshika, you asked this question. Would you like to verbalize it?
Actually, it was partially to encourage others to come in with more questions, but I think it is one that I wanted to just point out that I love this cluster, that it's part of the implementation strategies. But we also found that this is the cluster where we found the most opportunity to expand and add more strategies, as we are working especially with community-based projects. And so I just wanted to put that out there, that it sounds like you are also suggesting more specificity, but perhaps more strategies could also emerge here.
I totally agree. And that's what I'm starting to find in my work, even though the some of the active testing and results of what those expanded strategies could be, at least in my line of work, is right. I'm right on the cusp of that. So I don't know for sure what those might be, but I'm getting a real sense, some early signals that absolutely there could be more strategies and more specific. I absolutely agree. And again, there's, other fields, community engaged researchers, health promotion folks who already know a lot about this. And that's one of the beauties of implementation science, is we all bring different disciplines, our own disciplines, to this effort. Well, and let me dive into, whenever we get into some examples in just a moment, there are some ideas I have about other types of strategies, and we'll see how you all respond to that. Okay, next slide, Carrie. So my team and I developed tools for implementation practice on how to engage consumers, especially those who experience marginalization. When we say consumers, we mean the end user, the ultimate recipient of the innovation in healthcare, that's patients; in schools, it's students or their caregivers; in criminal justice settings, it's people who are incarcerated. It could be the community where you're at. And we call these tools consumer voice. And one hospital manager that we interviewed said, "We would really love to engage more patients when we implement new services, but we just don't know how." And I could relate to that. Now, these tools are not to be um, mixed up, confused with the speaker you had last in this mini series, who brought tools for environmental assessment, that was engaged with community. And those tools were called Our Voice, although that's a great name. And I'll be sure not to not to name it that. But I know doctors Wagner and Carlson presented on those. And so just to clarify, you're hearing a lot of voice, but they are different things. Okay, next slide. Often in healthcare, whenever we work with stakeholders or when we work in any setting, we work with people at the organization, and they're all up there like the parents above a baby crib designing a mobile, and they are putting things together. They're coming up with ideas, and they say, "I love this. Yeah, me too. This is really good. This is really going to help people." But then the end users come in, and all they see is what the baby sees, which is butts. It's just butts. Hopefully all of us are have gotten healthcare, are getting healthcare. Do you know those times when you go into healthcare and you think to yourself, did anyone think this through? Did anyone, did they put any thought into this? And the answer is yes, of course they did. They just didn't think about it for you or from your lens. And that is another reason why that end user, that consumer involvement is so essential, not sufficient. We need all the other stakeholders or people in the organization working and adapting as well, but we definitely need the end user's experience to be incorporated. Okay, next slide. Consumer voice is a set of tools that's generalizable to any setting and free. So we did some pilot development, and we're pilot testing them now in the case of suicide prevention for veterans in the United States. But they are generalizable to any other service user, schools, community settings, etc. They are available for free on Google Drive. It's a very simple setup on Google Drive because I had $0 to make it. But interestingly, in a lot of our user testing, people like it, like the Google Drive. If you are a VA employee, we have a fancier version on a VA SharePoint that's freely accessible. And I'll make sure that that gets included in the resource page that you all get otherwise after here. Go ahead and click. I'm going to show you a little bit about how we made them. This is our design team, and we made the decisions after we did a lot of data collection. I'll show you, and ultimately we were the ones who made the decisions about what stayed or what went. And we had lots of different scientists and implementation experienced people involved, but we also had consumers and end users from our healthcare setting as well. Next slide. So we used human-centered design to develop consumer voice. So over an 18-month period, we engaged in healthcare, relevant to healthcare, we engaged patients, we engaged community organizers, community engagement experts that work in research, implementation scientists and implementation practitioners, and clinical leaders in healthcare. And what I'm about to show you is a lot because we did a lot to develop these tools. Click. Thank you. So we did some initial data gathering in an environmental scan and some expert interviews. And then using that initial data, we went in with some questions in 30 individual qualitative interviews. And at the same time, those interviews with the same people, 30 co-creation sessions where they actually created in real time some really rough prototypes of different tools with us. And then we engaged in a rapid qualitative analysis and created a full set of prototypes. We went to step 2, many uncontrolled pilots with 11 implementation practitioners who used our tools for a month. And then we did focus groups with them. If you'll click, Carrie. We then did more rapid qualitative analysis and refined the prototypes again. And then in step 3, we did basically a lot of group exercise with 15 prior participants that had already seen them to resolve additional issues. And we identified the need for more user testing with clinicians specifically. So we did that. And that was step 3. And if you'll click, Carrie, we did more refining of prototypes. And then we have the end result, which are the final tools we have ready. Here were 5, oh, you can go next. Yeah, next slide. These were 5 core principles that we found for engaging consumers in implementation practice. Click. Really listen to others, especially consumers and community members. And particularly people in positions of power need to prepare to do this. And if you are on this call, you are probably a person in a position of power relative to someone outside of your organization who is receiving services or you want to receive services there. So we need to prepare to really listen. There are several ways to recruit and engage consumers, many, many ways, and you should use multiple. Okay? Next, or click. Sorry, Carrie. There's 5 things we're gonna go through here. Work with diverse groups of people involved in the problem. So, there can be an issue in community engagement or consumer engagement stuff that you end up getting, you might have like community engagement or representation, but it can be like highly professionalized, end user representatives, like that the patient that you're working with, but they actually have a PhD in an adjacent field also. um, and that doesn't represent much of the population. um, so working with diverse groups of people involved in the problem was seen as really core. Click. Set clear expectations, clarifying roles, orienting people very well, and then clarifying how work will get done to make sure, it minimizes upsets and people work well together and can sustain, but also can sustain through bumps and barriers in the road. Click, one more click. Our 5th core principle, repeatedly show how consumer and community contributions are valuable. And all of these, our tools are built on these 5 core principles. They have different modules, but they all really address some of these things. And the ultimate theme that all of these core principles fed into was building trust. And all of our user testers, all of our people who informed us and educated us really made clear how each of these things helped to improve trust and build trust. Okay, we have one question. Nicole, do you want to unmute and share? If you can, I'll read it.
Sure, no, I'm happy to. I was just curious, and sorry if I missed this. When you launched on these, HCD activities, was there a particular kind of problem statement or sort of North Star that you had people focus on? What would make your care experience, optimal, or what is getting in the way of you being able to access care? Just curious.
That's a great question. We did. Carrie, would you go back to the slide with the whole human-centered design development? Yeah, thank you. Okay, so when we did this step 1, all the interviews with the co-creation sessions, we, and again, we were engaging all these people at the bottom. So we definitely had patients and community organizers, but we also had, researchers and healthcare leaders. And we gave each different group a scenario that was our North Star that everybody started with. And the scenario was about, them either being asked or them being told to ask to engage patients with a certain health condition that was relevant to them in the rollout of a new program, in how to start that up. So we actually didn't ask them about involvement in their own healthcare. We asked end users about, if we were to approach you about, helping us actually roll out a new, psychotherapy or start offering a new program for this or that, what would you think about that? And then we really talked, that took a 35 minutes probably of each interview. But if it were leaders, we asked them, what would it be like for you to try to approach and make that approach people and make this happen? And then we really got down to to understanding where people were struggling and what they thought about those ideas. And then we used a technique in human-centered design called the 5 whys, which is when you basically just ask the question why 5 times in a row. And so someone would say, well, I think this or this, and we'd say, and why is that? And they'd say, well, it's like, X, Y, or Z. And you're like, and why do you feel that way? And suddenly you're doing something that actually is not dissimilar from a technique that we use in psychotherapy, which is really drilling down to a core belief or a core need. So that's what we used as our North Star, and also how we kind of got more, eventually refined. Okay, let's keep moving, and I'm going to show you these tools. Carrie, if you will get us to the slide after, the 5 core principles. Okay, here, if you go open the Google Drive version of Consumer Voice, it looks like this. So you can see on the left that there's 13 modules. And what's great about Consumer Voice is it's modular, meaning you can take what you need and leave what you don't. We also explicitly designed it and got a lot of feedback from people who were beginners at this, intermediate, and advanced. And so if you are really experienced with community engagement, there is still something here for the advanced learner. If you're brand new, this is going to walk you through it. You don't need to do this in order from 1 to 13. You can simply jump in to a module and learn how to do the skill that is the title of that module, such as clarifying teams and roles, or identifying who should be involved, or how do I make people feel included, or something a little more advanced. How do I co-lead with a consumer or an end user? How do I make action plans? If you want to just do this in writing and you want to open a massive PDF and read everything we wrote, it's also in the written guide for you. You can just read. Let's see, Carrie, are you able to click and show an example of a slide? We have, in each module is a set of slides, and they all have, they're all written in a way that's 508 compliant, meaning they can be read by a screen reader if you need that. They also have audio voiceovers. And so it's me or someone else on my team, not only reading some of the slide, but talking and elaborating more, which can be interesting. Carrie, if you're showing something, we are not seeing it, but that's no problem. Don't sweat it. Don't worry about it. There's also a cheat sheet in each module. If you want to get started quickly and you want to read half a page and jump in, we've summarized it in there. If you'll click next, Carrie, I'll also show you that there are some supporting documents. So if you open a folder, like this is create ways to get input, you can see those slides that says create ways to get input. It has the listening time if you wanted to listen to it, which is 14 minutes. All of the modules, with the exception of one, are 14 minutes or less. One had a lot going on, and it's like 21 minutes to listen to. But otherwise, they're usually like 14 slides, less than 15 minutes if you listened to it, probably even fewer if you read through them. You can see the Get Started Quickly slide, and then the supporting documents have things you can read further if you want to further your knowledge, and we have templates and worksheets that we reference in the slides. Like if you want to do this, go look at our template in the supporting documents, and you can use it. Everything is in PowerPoint, so you could actually then take the slides and edit and present them. If you need to get other people on board with this, you don't have to recreate it. You can just use our slides. Please just credit us. The supporting documents are all in Word, or they're in fillable PDFs, so they're usable for you. Okay, let's go next. So here is an example. So we are in, if you're not sure where to start, we have a how to use Consumer Voice module, and it's 10 slides that you can kind of see on the left. So you read the slide, you can work ahead and skip slides if you want on the left. And you can listen if you go to the little audio recording on the bottom right. So like this is an example of the top 3 modules we suggest based on your level of experience with consumers. Like if you are a beginner at this, you know, you might want to start with these 3. If you're more advanced, you might want to start with normalizing mistakes or working on inclusion, for example. So that's kind of what it looks like. I think that's the end of this. Oh, you can read more about the development of it in this paper we published if you'd like. Now let me pause for any questions here before we move on to some examples of using it.
I am not seeing any specific questions in the chat right now, but I would like to encourage our participants to take an advantage of this moment and post any questions. I did want to say that I'm just so impressed by the level of guidance that you are providing to people to be able to implement this. I know that many of us are working on innovative ways of doing things, but the guidance always comes much later. And for you to incorporate this so readily, I think we just have to be grateful for that.
Thank you. Thank you. Thank you for seeing that. Thank you for seeing that. That comes out of, I'm navigating these worlds myself, and these came out of needs that I'm also having. So, you know, usually what some of us need, the rest of us do too. Okay, if you have questions, put them in the chat. We'll keep rolling. Okay, let's look at some examples. Okay, and I've applied these. I have a background in HIV prevention, so I applied these in, there's 2 examples I want to show you. This first one is a real example of using consumer voice and how you might be able to use it in, you know, ending the HIV epidemic. So we are doing a hybrid 3 effectiveness implementation study on implementing depression care in HIV clinics for veterans of the US military and VA. My colleague, Dr. Jacob Painter, and I out of Little Rock are the PIs of this R01 level grant, and it's just starting. So we haven't started implementing yet. We haven't used consumer voice yet. We're right on the brink, truly a month away. Okay, let me show you what the study design is and kind of how we've built in consumer voice. So it's over 4 years, and here's our aims. So first, we have an implementation aim, an effectiveness aim, and an economic evaluation aim. We want to determine through a cluster randomized trial among VA HIV clinics or infectious disease clinics, the effect of adding external facilitation as a strategy to other implementation strategies that consist of having a site level clinic champion in each clinic and a learning collaborative in which they come together for peer learning. And then an effectiveness aim to actually determine the impact of the depression care, which is a nurse care manager, on patient level outcomes, depression and suicidal thoughts in this case for veterans living with HIV. And then there's an economic aim to actually estimate the budget impact of those strategies, and by calculating the cost of what it takes to deliver consumer voice, the clinical champions, the learning collaborative, and facilitation. So next slide, Carrie, we'll take a look at a visual. So we've assessed some sites, some clinics at the top, and now we're working on finishing enrolling 8 HIV clinics from about these 60 sites, and it will be around 480 veteran patients that are living with HIV and experiencing depression. And then we're going to randomly assign 4 sites, 4 clinics to the first implementation arm, which is what we might consider like a lower intensity implementation. They have a clinical champion, they have this learning collaborative for people at those 4 sites, and everybody gets consumer voice tools as well. Like what I just showed you, they will just get that, and that's it. Arm 2, the other random assignment arm, is everything I just mentioned, but they've got an external facilitator. And that external facilitator will use consumer voice. And that external facilitator also has a facilitator consultant, that's me. And then we will work on implementing this depression care intervention, and then we will assess implementation, clinical, and cost outcomes at 12 and 18 months. So that's about to start, and that will give us a couple of things. We will have, we're not testing the effectiveness of consumer voice because both arms are getting it, but we are doing a really deep process evaluation of consumer voice. If you could click, Carrie, for some animation in here. So you can see that's where consumer voice comes in. And next click. The process evaluation will answer, what will the clinical champions do with consumer voice? If we just give them these tools, even though they're really meant to be user-friendly, they were heavily designed by users and we're continually refining them as we get feedback, will they do enough with them? And they will also be given a financial stipend to financially compensate any end users, veterans living with HIV, that they engage in implementation. I forgot to say that. Both arms will get that. Like, they will be able to give that money to end users, not keep it themselves. And then what, on the other arm, what will facilitators do with consumer voice? And then how will patients end up engaging differently between arms? And because we're also looking at maintenance outcomes like 18 months later, I have also built in some process evaluation of like, how much did they sustain any patient engagement element here? And I don't know. Click next, and here are some potential results. I think that this comes back to Borshika's question at the beginning about, seeing a lot of room for expansion in the engaging consumers cluster. I think it's possible at least two things will happen: that there will be implementation strategies that interface directly with end users or consumers. And Carrie, if you'll click, I just put some examples that I could imagine. Media that's designed with and for veterans living with HIV and depression, that's on the waiting room TVs, that goes out in mass emails from their healthcare system and in physical mailouts to them advertising the intervention. If you'll click next. But I could also imagine implementation strategies that interface instead with clinicians or managers, but they were designed with end user or consumer involvement. So that could be like workflow changes to screen for depression and discuss positive screens in a way that's more patient-centered than maybe if consumers weren't involved. Click next. Oh, my animation got wonky. Let's volley back over. Let's hit the tennis ball back over to the other side. An implementation strategy that could interface with end users could be like having phone waiting messages when they call the clinic that describe the benefits of treating depression, for example. And it could be in the voice of veterans that living with HIV and depression that are saying, it helped me and this person sounds like me. And over back to the other side, an implementation strategy that would interface with clinicians or managers, but be designed with end user input, could be like a sustained community of practice for other innovations in infectious disease clinics. And it would have clinicians and leaders, but also by that time, maybe some really engaged, knowledgeable veterans living with HIV who are able to continue weighing in and then find their networks to build up, an actual sustained community of practice that actually had regular consumer representation in a more meaningful and diverse way than it can be sometimes. So those are some potential results I could envision. I don't know, but that's one thing I could see coming out of this. Let's go to the next slide and look at example number 2. This is a completely made up example, but it is based on some true things. And I cite the true things where they are. Okay, so let's think about interventions to prevent HIV among Black women in the Deep South in the United States, an area that still has a much higher incidence across the country in terms of HIV acquisition. So there is currently an intervention that has been shown to help with reducing sexually transmitted infections and to increase HIV testing and connection to treatment, that involved 2 4-hour group sessions and 4 telephone calls over a year. And these all focused on personal, relational, sociocultural, structural factors associated with adolescents' HIV risk. And this also came with vouchers for male partners' HIV testing and treatment. And this was shown to be effective with Black adolescents, specifically young women and girls in the Deep South. And so the Deep South is areas close to my neighbor next to me in Arkansas. This is like Mississippi, Alabama, Louisiana, Florida, Georgia. And let's say that theoretically this intervention was adapted to include a component also to address intimate partner violence, which we know is a big HIV risk factor. Okay, so that's our made up example. Now, what scientists know? One of my colleagues, Dr. Karen Johnson at the University of Alabama, did this great with her colleagues, did this really great narrative review on HIV and intimate partner violence efforts targeting Black women in the Deep South. And so they learned one important thing from that. Well, they learned two important things. One is that this group of people is highly overlooked in this area. But second, if you'll click, Carrie, they learned that there were some HIV protective factors for these women who are experiencing intimate partner violence, and to either reduce the violence and or also reduce their HIV risk. And it was spirituality and religiosity. It was living with a partner and social support. Now click, what is still unknown? Okay, at this point is, what would be the best implementation strategies to enhance the uptake and spread of an HIV and intimate partner violence intervention among Black girls and young women in the Deep South? So if we have this intervention we know works and we adapt it and it's workable to have this intimate partner violence component, what are the best implementation strategies to enhance the uptake and spread of that? So maybe that's their question, okay? Next, we'll see what they might do. And to address that question, they could do a formative evaluation or a diagnostic assessment, if you will, over 9 months. And let's say they assemble a research team and they use consumer voice to help them create and meaningfully assist an implementation research team with a lot of different people that could be involved, including people affected by this problem. So Black adult women in the Deep South who've experienced intimate partner violence in the past, let's say they want to, roll this out in schools and educational settings. And so they want school administrators there. They want some actual students who are attending, some implementation practitioners and scientists to offer their knowledge, and perhaps a Department of Health liaisons that work with their HIV prevention task force, for example. And then what they might do, if you click, Carrie, some of the methods, that they want to identify the barriers and facilitators to uptake in that good assessment. So they could do a walking survey, or your last speaker with the environmental assessment, they could do that. That would be great at the school. They could do group interviews with current students. They could do surveys of some of the adult caregivers of the current students. And here and the next bullet, they want to make sure they talk to school staff and administrators as well. And ultimately, if you click again, based on their analysis, they will have a good list of what they anticipate to be barriers and facilitators to starting this intervention. And then they could use an implementation mapping process to identify and design strategies. But it's all done with and by the research team on the left, that you can see includes, in fact, 2 different levels of end user involvement or people with lived experience. And so it's likely that those strategies, but the process to do all of this implementation study, but then starting with the implementation practice, actually selecting those strategies, designing them, envisioning how they would actually work, is also very informed by the consumer's voice, and using consumer voice tools to make sure that those voices are included, to, as the partnership goes on, as people make mistakes, using consumer voice tools to start to normalize some mistake making and correct course, to finding some of those individuals with lived experience that sort of start to stand out among the crowd and want to be more involved and pick it up quickly. And they might use consumer voice tools to start to co-lead some of this implementation practice in their next step with a consumer co-lead and an implementation lead together. So those are some examples I could think of how the process would work. Carrie, if you'll click next, these are just some potential examples of strategies that could interface with end users, and you can just click through them, Carrie. Could be financial incentives for the end users, educational text messages about intimate partner violence that go out to students. And then there's some examples of strategies that interface with the school admin or educators, but again, they're designed with end user consumer input. And click for a few examples of those. Developing an implementation guide that could be piloted at 1 to 2 schools and then could be refined to be a key document for other schools and spread. Revising a workflow so that the the school nurse can host like a private check-in hour daily during lunch, for example. Maybe that's something that, students at that school with that end user voice and experience would say, that's what we need, is some privacy and some daily reliable time. Could be creating a coalition between people and having, again, regularly some of that end user, people with lived experience involvement. Again, I don't know what the result would be, but those are some potential results I could imagine. Okay. Oh, there's that one. Set up a data monitoring plan. We got to do that. Now, let's go to our next slide. We are piloting consumer voice right now. If you'll click, we describe it in this protocol paper. And also, if you click, so we're doing the process evaluation I showed you in the HIV clinics, but right now I am in the middle of piloting it related to rural suicide prevention. And we are unfortunately or fortunately already renaming it as well. Turns out that as we released, a lot of people who never came up in the user testing had a problem with the term consumer. So we are renaming it and taking suggestions. If you have some, we would welcome that. Okay, let's pause there. What questions do you have about that so far? Just let them on in the chat.
What are good ways for us to share tips with you in the chat or for new names?
Yes, I mean, I would love tips in the chat, but I'm also going to re-put my email back in here because I would really like to hear any thoughts you all have and on renaming consumer voice. But also, if you start to use these tools in the Google Drive version or the VA website version, there is a feedback survey built right into it. And so you could anonymously put your feedback in there because we are refining it at regular intervals. Someone asked in the chat, I mentioned using consumer voice. We're piloting it. It's described in this protocol paper you're looking at on the screen, that it's basically we're doing quality improvement with a suicide prevention intervention in rural areas. Actually, this is true in many other countries besides the United States, but also the United States, that rural areas tend to have a higher suicide deaths than cities. And so getting more sustainable suicide prevention healthcare and intervention in those areas is important. It's not the only solution to that, but it's important. So we're doing some quality improvement and we're using consumer voice at some sites and not using it at others. And we're piloting to kind of see how acceptable and feasible it is for practitioners to use and for some of the rural communities to engage with. And we will see when it comes out. So probably a year from now, look for that. Okay, well, I want to reorient you to, you can stop sharing slides, Carrie. I just want to reorient you to that question I posed at the beginning, which is, what is the most elegant next step for you? So you've heard a lot here. And you might talk with your colleagues about that. You might, think about that for yourself and some private reflection you have. What would be the most elegant next step for you in your work? I know that some people we're going to have consultation here. And I look forward to that. And otherwise, if you're rolling off now, thank you so much for joining. To our wonderful host, thank you for inviting me. Thank you for coordinating this. I'll turn it back over to you.